With emphysema is basically one-way valve. You've got air going out, and that's why they have to grunt. That's why it's so hard for them, because they're trying to exhale against the glass airway. Now, inhale, okay. When we inhale, as long as I open up the exhale, that's what's going on. Inhale, exhale. So they're really struggling. And patients like that is going to be having major trouble keeping their PO2. Cavity? Everybody agree? So what would be the considerations?
Infarction.
I mean, it looks pretty well defined, doesn't it?
Yes.
Yeah, but being basal and peripheral, infarction, absolutely. Infarctions, though, tend to be kind of like staph cavities. They tend to be fuzzy, thicker wall, but fuzzy. This is more well-defined, isn't it?
Yeah.
Well-defined, could be tumor. TB's well-defined, kind of wrong place for TB, though. Fungal, they tend to be a little more well-defined, thin wall.
Coccidio.
Yeah, fungal, coccidioidal, absolutely. Yeah. It's the right place for infarction, but not really the right appearance. If it was a fuzzier margin around there, then absolutely infarction would be strongly considered. So where do we think it is?
7, 8.
I think probably anterior 8 mostly, probably extending a little bit into 7, but it's probably originating in 8 anterior. All right, here's something completely different. That one helps me to put it up right. This one and this one are all different variations of the same problem, and this is something that we're going to talk about after the tumors. Emphysema is right after we're done with the tumors, then we go into a group of miscellaneous things, which is where emphysema and this one, and this one. And so what we kind of our theme here today is kind of hyperlucency. And as we saw with emphysema, that hyperlucency can come from internal in the lung, but it can also come from pleural. Just like we can have localized water from pleural, we can also have hyperlucency from pleural. This one is really tough to see, but can you see this faint line right here?
Mm-hmm.
Coming down like that? That goes all the way down to about here. That very faint line is the edge of the lung, because what do we notice beyond it?
No vasculature.
No vasculature. A little bit more lucent and no visible vasculature. Just like over there, we had hyperlucency and no visible vasculature. Well, hyperlucency and no visible vasculature equals then there's no lung there. Then there's no lung there. Just like that one. Those are bulla. And as I said, stick your finger in there, there's nothing there. It's just a big hole. It's just a big hole. But here, this is the edge of the visceral pleura because the patient has air in the pleural space, which is pneumothorax. Liquid in the pleural space is a hydrothorax or pleural effusion. Scar in the pleural space is fibrothorax. So you have pneumo, hydro, or fibrothorax, and that means pleural space, air, liquid, or scar. And all three of those are going to do what to the lung?
Compressive.
Passive atelectasis, compressive. Because it's externally just pushing the lung in and out of the way and just pushing the air out of the airway. There's nothing wrong with the airway. So it's called passive for a reason. Absorption is active at atelectasis. The lung's actually doing it wrong. But passive, the lungs are being like pushing. When you have pleural space, the two layers are supposed to be together. If you separate them, then you've got to compress the lung by the same amount. That is a small pneumothorax. Not even a great, maybe slightly loosened compared to over here, but not even much of a change in density. This one's even less. This one's a pneumothorax also. Very faint. I know where this one is, and it's tough to see it. It's actually right here.
Diaphragm rising on the opposite side, is that because of that?
No. No. Yeah, I mean, that's not enough to be, you know, a difference in the diaphragm level. But here's a good example of the difference between inspiration and expiration. Now you can really see it, can't you? Much easier to see on expiration because the lung increases in density slightly. And you still have the same radiolucency out there. So it's much easier to see it on expiration.
So the bronchivascular markings will end where the visceral flora ends, and then there won't be any more.
And there's no markings out here at all, because there's no lung there. There's no lung. So what you get is that very faint line, which is the visceral pleural edge, and then it's hyperlucent beyond that. That's the classic pneumothorax finding.
That's like the tapering.
So you said
Yeah.
the reason why we see it more with expiration is because the lung density goes up.
Yes, and this stays the same, and the lung density increases with expiration. And all it does is give you a little more contrast, so it makes it easier to see. And all it's doing is confirming, because this is really tough to see on this one. And so typically these patients have chest pain and difficulty breathing. This is going to be real mild chest pain. Typically happens very suddenly. And if it's not a penetrating trauma, which we don't see those people, we don't see gunshot wounds and stab wounds and fractured ribs sticking out through your chest wall. But we can see people that coughed or sneezed and popped a bleb. Did Dr. Bordini talk about blebs? A bleb is just a little pocket of air right underneath the pleura. And when you cough or sneeze and pop a bleb, that air, because the visceral pleura ruptures, that air leaks into the pleural space. And that's how you can have one with a completely closed chest and you didn't do anything except cough or sneeze. Now you got a pneumothorax.
How common is that?
In the world of pulmonary pathology, fairly common.
Yeah.
Did we just drain the air out of it?
Yeah, the air's got to come out. Now, one like this,
Right away?
see, we don't know from one film in time, whether this is going to end up doing this. That we don't know. This is a pneumothorax, but that may be just a fixed volume of air, a static volume of air. If it keeps increasing, though, because the diaphragm's just going to keep going up and down. If there's a tear in the pleura, it's going to suck air into the pleural space. Well, what oftentimes happens with a pleural tear is you get a flap. Inhale, exhale. And the air pushes the flap closed. So then you got air going in only one direction. The air can't come back out of the pleural space. So then you increase the volume of air in the pleural space. As you increase the volume, the air is under greater pressure. That's where the term tension pneumothorax comes from.
Like a stab wound.
Like a stab wound. Even somebody that pops a bleb can end up with a tension pneumothorax. If they get a flap tear, and even from a cough or a sneeze, you can still have a flap tear. The diaphragm goes down, sucks air out, tear. Diaphragm comes back up, the air pushes against the tear and closes it. So you got this. You got a one-way valve again. This is how you die from a tension pneumo. Because where's the heart? This is left. Heart's supposed to be here. Look at how this is uniform lucent. Ribs, see the ribs as having pneumothorax. Because then the ribs show up beautifully because you don't have all that lung in the way and all that density from the lung. Heart's over here. And now you push the heart up against the chest wall. It's like you're squeezing the heart. How's the heart going to fit? How's the heart going to function if you squash it up against the chest wall and push it up against the chest wall? Which is what this is doing. This can happen really fast. Yeah. Some people can do this just in a matter of minutes. You got a big tear, yeah, you can fill the pleural space up with air and compress the lung really fast. Sometimes it happens a little bit slower. But people they have difficulty breathing, noticeably difficulty breathing. This patient's going to have major difficulty breathing. And when you compress this lung completely, push the heart over into the right lung base, then you compress the right middle lobe, right lower lobe, the patient's functioning on 1, 2, 3 up here.
This is where they would like
That's all I got.
stab them with something that would
Yeah,
open
it
up
can be
the-
stab wounds.
But I'm saying in an emergency.
Now, the way they treat this, yes, they make a quick incision between the ribs, stick a tube in, hook it up to a pump, and start sucking the air out.
Yeah.
It's called thoracentesis. And once you get negative pressure back in there, just lung gets sucked right back to the chest wall, and the breathing improves dramatically. Yeah, this is a surgical emergency. This is a now surgical emergency.
But say if you had like a stab wound, couldn't you just open up the stab wound and that would actually allow the air to go out?
Sure. Depends on how big the stab wound is, though.
Yeah.
It's a bad problem, pneumothorax, and I've seen a number of these walk into chiropractic offices. Even tension pneumos, I've seen those walk into a chiro office. We'll talk about one in class that we had in the clinic here.
What did you say the scar one was?
Fibrothorax, yeah. Pneumo is air, hydroliquid, fibroscar. All in the pleural space, all cause passive atelectasis. Yeah. See, this patient's got major passive atelectasis, don't they? Entire left lung and the whole right lung base is all passive atelectasis. So they're only operating on a little bit up here. Look at the trachea,
Yeah, that's what I was looking at.
way over here. So it's pushed the whole mediastinum over into the good lung.
So this would be something that happened pretty fast because they would.
Yeah, this likely would have happened, this could have happened just in a matter of minutes in some cases. But this is how people die from pneumothorax. They die because it just compresses the heart stops.
So say if they're, that's also my next question, if the heart is being compressed, would they have lower blood pressure? That's
Oh,
what
yes,
blood pressure?
sure. Because once you can't pump, blood pressure just goes to hell in a handbasket. There's no blood
I
pressure.
haven't heard that in a minute.